Hello everyone. So continuing with the conjunctiva part, the next topic will be the pterygium. First, what is pterygium? Pterygium is basically a benign, triangular, fibrovascular subepithelial in growth of the degenerative bulbar conjunctival tissue. So it is basically a triangular growth and it is subepithelial ingrowth of the bulbar conjunctiva extending over to the limbus on the cornea. And it is derived from a Greek word which is known as pterygion, which means a little wing. So it is a wing shaped triangular growth. Next, what are the risk factors in epidemiology? It is also referred to as the surface eye. It is associated with basically UV radiation. It is most important. Most important risk factor is UV radiation. It is more prevalent in pterygium belt region, which is located in warm equatorial climates. Beyond UV exposure, other risk factors include chronic ocular irritation, that is number two, from wind, dust, sand, and pre-existing dry eye conditions. It occurs in adults over the age of 30 years. Mainly males are included because they have to work outdoors. So next, coming on to the pathophysiology of the condition. First, there is UV light related damage. That is due to chronic UV exposure. It leads to oxidative stress, and this oxidative stress leads to p53 tumor suppressor gene mutation, and this mutation leads to growth of the mass or the pterygium. It also leads to stem cell deficiency. So some localized alteration or deficiency of these limbal stem cells. It leads to what? There is no barrier, and if there is no barrier, it will allow the conjunctival tissue to invade the cornea. Next, there is a fibrovascular growth. So it is basically a elastotic degeneration. What is elastotic degeneration? We'll discuss it in the next slide. There is elastotic degeneration of the collagen and active fibrovascular proliferation. And due to this, there is progression of this lesion. So next, what is elastotic degeneration? Elastotic degeneration is different from elastic degeneration. So this is the histopathological image of the pterygium lesion. And as we can see, these blue areas, this is the elastotic, elastotic degeneration. We can stain it with HNE and they are not degraded by elastases but stains with elastin. So this is a important feature that they stain with elastin but they do not degrade by elastases. That is why it is elastotic degeneration and not elastic degeneration. Next, what are the structural components? The pterygium has been divided into three basic zones, that is the head, the neck, and the body. The head is the apical portion that rests on the cornea. So if this is the cornea, and for example, we take this as a pterygium lesion. So this is the apical region. The part which rests on the cornea is the apical region. The constricted part is the neck, and the rest part is the body, which is the fleshy vascularized portion on the sclera. There's also a cap. A cap is a grayish zone which is located just anterior to the advancing edge, which indicates active growth. And what is a Stalker's line? It is a brownish line which is seen as a iron deposition in the corneal epithelium, suggesting a chronic static pterygium. So next is the diagram which shows the various part which we have seen in the previous slide. That is the head, the neck, and the body. So head is basically the apical portion which is present on the cornea. So neck is the limbal part, and next is the body. Body is the part which is present between the limbus and the canthal region. So next is the clinical presentation of the condition. So first, in early stages, it is often asymptomatic and it may present as a cosmetic blemish, which is noted by the patient. There is slight irritation and foreign body sensation with redness due to disruption of the normal tear film. So normally, due to the presence of this pterygium over the area, or if it is less than this, when there will be blinking, there will be irregular spreading of the tear film. And due to irregular spreading of the tear film, it leads to irritation and foreign body sensation. It also leads to visual blurring. It induces with the rule astigmatism as the tissues pull and flattens the cornea horizontally. So this pterygium will pull this ways and it will flatten the cornea. And when the cornea will be flattened horizontally, there will be with the rule astigmatism. With the rule is when vertical is more steeper than the horizontal. Next, there will be visual axis obscuration if it covers the pupillary margin. It is typically located on the nasal side due to the light focusing from the temporal periphery across the anterior chamber. It also leads to diplopia if there is some amount of restriction restriction of extraocular muscles. So there is another term which is pseudo-pterygium, which has to be differentiated from pterygium. So what is a true pterygium? True pterygium is basically a degenerative process. As we have seen, it is a type of elastotic degeneration, whereas pseudo-pterygium is an inflammatory process and it is basically post any trauma due to chemicals. Mainly pterygium occurs in adults more than 30 years, whereas pseudo-pterygium can occur at any age. The true pterygium is strictly located in the palpebral fissure and is usually nasal, whereas pseudo-pterygium can occur anywhere around the limbus. It has a positive probe test, that is, probe passes beneath the neck, whereas the probe cannot pass beneath the true pterygium. It can be progressive or stationary, whereas pseudo-pterygium is always stationary. It do not grow further. So this is the figure which shows a pseudo-pterygium. First of all, it is post-chemical injury, and due to severe inflammation post-chemical injury, there is growth of the conjunctiva onto the cornea, but it is not a true pterygium. It is not a true pterygium. Next, basis on the corneal involvement, there is a grading. First, the head of the pterygium crosses the limbus but less than 2 mm onto the clear cornea is grade 1. Grade 2 is when the head covers 2 to 4 mm of the cornea, that is midway between the limbus and the pupillary margin. So if the pterygium is up to here, it is grade 1. If it is between the pupillary margin and limbus up to here, it is grade 2. And if it goes beyond the pupillary margin, that is grade 3. And it threatens the visual axis also, and it will induce astigmatism also with the rule type. And what is grade 4? When it completely crosses the pupillary margin, causes severe visual impairment and requiring surgical intervention. Also, on the basis of progression, it has been divided into progressive type and a regressive type. So what is a progressive pterygium? When the pterygium is thick, fleshy, and vascular, and there are presence of few infiltrates in front of the head of the pterygium called the cap, it is a progressive type. But if it is thin, atrophic, attenuated with very little avascularity and no cap, ultimately it becomes membranous and but it never disappears. It is a type of regressive pterygium. It is very membranous with no vessels. So when we will come to the management of the condition, it is basically to counsel the patients that medical therapy does not cure or regress the pterygium. First, we'll prescribe a topical lubricant, that is artificial tears or ointments. We can also give mild topical steroid, and we have to advise the patient to use sunglasses for their protection to halt or slow down the progression. What are the indications of surgery? First is visual axis threat, the primary indication if it encroaches upon or directly threatens the pupillary axis, that is grade 3 or 4. When there is severe astigmatism, that is significant uncorrected visual blurring due to pull of the fibrovascular tissue. When there is chronic inflammation or recurrent episodes of severe redness, foreign body sensation, and irritation. When there is restriction of motility, it restricts the ocular movements, causing diplopia. It is an indication of surgery. And if it is a cosmetic blemish. So, what are the various type of surgical interventions available? First is the bare sclera technique. It is simple removal of the tissue. Whatever the pterygium tissue we have, just remove it. And removal of this tissue is bare sclera. Since after removal of this tissue, only bare sclera will be available, so it is a bare sclera technique. It is not acceptable now because of high recurrence. Up to 80% recurrence is present with bare sclera technique. Second is the conjunctival autograft, which is the gold standard. So what we do in this, first we do bare sclera technique only. After that, we take a graft from the superior conjunctiva and place that over the bare sclera. And the recurrence rate are very less in this. Why we take it from the superior bulbar conjunctiva? Because superior conjunctiva can be protected by the lids, and also superior fornix is very deep. So we can take it from the superior part. Third, the graft which we have taken, we can secure it with the help of sutures or fibrin tissue glue. But if we use a fibrin tissue glue, it offers faster surgery and lesser postoperative inflammation. Next important technique is the amniotic membrane graft. After doing the bare sclera, if the defect is very large, then we can place amniotic membrane in place of the conjunctival autograft. Since there is high incidence of recurrence with this condition, to reduce recurrence, we can use mitomycin C or 5-fluorouracil intraoperatively to inhibit the fibroblast proliferation in high-risk cases. There are also other techniques which are modification of these techniques like perfect surgery, perfamed surgery. So what is a perfect surgery? A perfect surgery is pterygium extended removal followed by extended conjunctival transplant. And in place of this conjunctival transplant, we use amniotic membrane, that is amniotic membrane transplant. These are the modifications of these technique, and this reduce the recurrence rate to up to less than 1%. So as we have already discussed, the most important or most common complication of pterygium surgery is recurrence. Bare sclera technique has up to 89%. Conjunctival autograft is a good technique, which is a current gold standard that has approximately 2 to 12%. Some studies report even lower rates at around 1%. Next is a amniotic membrane graft, which has around 10 to 30%. And other advanced modified techniques which we have discussed has recurrence rate approximately 2 to 3%. So other surgical complications other than recurrence, first we can see there is a buttonholing of the graft, that the conjunctival graft which we have taken has a hole in this. So it is the buttonholing of the graft. Second, there is graft edema. Third is a subconjunctival hemorrhage. Fourth, there is graft sliding onto the cornea. Fifth, fifth is the retraction of the graft. So this is the bare sclera which has been left and the graft has been retracted. Next is the granuloma. So at the donor area, there is formation of granuloma. Next is granuloma at the host site. And H and I figures shows the type of recurrent pterygium. Thank you everyone for listening.